I won't be near that funny, and I'm from Arkansas, so I don't talk near that fast. That was really, really good, Dr. Eisenberg, really impressive. I'm Jim Adamson. I am a consultant for Point of Care Partners. Many of you probably know us as the program manager for HL7's Da Vinci project. My work is in that space in payer-provider interoperability in support of healthcare administration. Today, we're going to talk with a great panel of experts about payer readiness, essentially, for CMS 0057. And we'll introduce the panel here in just a minute. But I want to kind of give some information just to bring everybody, level set with everybody on timeline. I joined the healthcare interoperability movement in 2018. That was the time that Da Vinci project was initiated. And it was also time that CMS joined the Da Vinci project in support of their work. Within a couple years, we had CMS 9123 out of the Trump administration, and that regulation which never really finalized, that regulation was, or is, the basis for CMS 0057, almost to the letter, some minor adjustments. So my point is, today's discussion, payers pick up the pace, and we might really say payers pick up the pace, and thank goodness, because the timeline for them to complete their work is just about a year away from now. And I would say very happily that payers have picked up the pace quite a bit in the last couple of years, and they are moving very quickly towards testing and productive capabilities across the fullness of CMS 0057. But there are a number of challenges that have surfaced as they have worked to move things into production. And so today with our panel, we're going to discuss some of those challenges and also some practical solutions that might help payers get past those challenges and be compliant, at least in one state, by 1/1/2027. So now, if we could go to some quick introductions before we get started, we'll start.
Maxim Abramsky. I'm working as a VP of Product Management for Edifecs, which is now Cotiviti business. I'm leading the product team, which is focused on payer interop, so everything TEFCA, FHIR, 57F is in my purview, and I am very pleased to be in this panel and share the perspective that we have from the vendor side in terms of what payers can do to adopt TEFCA more rapidly.
So John Blair, I'm the CEO of MedAllies, and then that was over 25 years. And as of the last 6 months, I'm also with the company Centauri Health Solutions. And MedAllies is primarily involved in operating national networks. And being introduced to Centauri has been very interesting because I think they have probably over 100 payer contracts. They do a lot of work with payers around benefits, data acquisition for risk management, or risk adjustment, HEDIS, gaps in care, et cetera. So that's been an interesting addition to what I've been used to doing.
Hey everyone, Jay Nakashima with eHealth Exchange. Thanks for having me.
Okay. Well, Jay, I'll start with you. eHealth Exchange facilitates billions of health data transactions annually. The last number I saw was 25 billion transactions a year. So that's a lot of lessons learned. And most of that's been provider to provider exchange. What lessons can we take from those many years of provider to provider exchange and apply to payer-provider exchange and payer-to-payer exchange?
Yeah, great question. So yeah, the vast majority of the transactions that we process, and I think it's similar with other QHINs and care quality implementers, is for treatment, HIPAA treatment purposes. And then a growing number of transactions for non-treatment purposes, for public health, for SSA disability determinations, a sprinkle of transactions for life insurance, and so on and so forth. But in the early days, and I wasn't at eHealth Exchange at the time, but in the early days, even provider-to-provider exchange was very limited. And when I arrived, it was limited. And that was for a variety of reasons. I think the number one reason was the infrastructure. So providers had direct connections, think direct interfaces with other providers. And it really, unfortunately, created an environment of selective exchange. So yeah, you might connect with another health system all the way across town and have a connection with them, especially if you didn't consider them to be a competitor. And what we ended up doing, and the entire market ended up doing, was creating a hub and spoke model. So, we learned that just having a directory wasn't enough. We really had to have an established connection with each of our participants so that they just had to create one connection, and then we do the heavy lifting and get them out there or get the connection going. Incentives, of course, always help. And I think the payers have that now with 0057. And I think the providers certainly do in terms of prior authorization. But I think at some point we're going to need to have incentives out there to really help with clinical data exchange, CDEX and PDEX, payer exchange.
Terrific. Guys, you want to chime in on that question?
Add anything? Well, so your question was lessons that can be drawn from treatment that may be applicable here, or how does it compare? I think the only lesson is the connectivity. A transaction's a transaction. Once you get past that to the stakeholders on both or either end, you're into another use case, and it can be a completely different animal. So for providers, transitions of care, getting information you need in an emergent situation or with a complex patient, there's a few places where that would apply to a payer. If a payer certainly wants the information to take care of their complex patients, and the more they can get of that, the better they can do, because they do handle some of those responsibilities or take some of those responsibilities in the whole care package for patients. But when you go beyond that, there's a lot of things that are different. You talked about prior auth. Now both sides want that, but payers need data, and they get it today. And will these national networks, TEFCA, help with that? Probably, and we're probably going to get into that later. But I guess the lessons that what you could draw from it is at least the treatment piece has paved the road and created the highways for this to now happen. But you're now going to have to get into new business reasons, different incentives that are different between payers and providers. So it's not going to be a one-to-one translation.
Right. Maxim?
There is also the perception that providers do not want to share data with payers, or if they do share the data, it's only administrative data like claims or claim attachments, and that is totally untrue. Today we process several millions of NPIs, data from those providers who want voluntarily to share the data with payers, and this data is clinical data. There are many reasons why payers would need that data to make providers' life easier. Things like care management, value-based contracts, quality. So there is very healthy exchange of data both ways. So when somebody says, well, this will never fly because providers would never agree to share the data with health plans, that is not true. It is happening now, and TAFCA is one of these facilitators, because the main question comes when you talk about this: how can I share the data? How can I ensure that security of my data is correct? Or how can I be sure that the data lands in the right hands? Like, this is the health plan which actually has this patient as a member. Things like that are being facilitated by TAFCA, and this is one of the good things that exist, because otherwise it will be just yet another set of multiple disjoint networks. That's my practical observation from the industry.
Terrific. So I'm a facilitator for Sequoia Project's peer-to-payer work group. I'm going to take a moment to dig down a little deeper into the CMS 0057 regulation and ask you guys about peer-to-payer exchange. Maxim, your company traditionally has represented the strongest payer interest on the floor, and now, John, you're digging into that space as well pretty deeply. You know, you mentioned to me earlier that you see both headwinds and tailwinds as you talk to payers across the country in their effort to get payer-to-payer exchange operational. Talk to us about that a little bit.
Yeah, so there are, it's a multifaceted topic. Payers definitely need to have data, clinical data, admin data, for various reasons. And when we talk to payers, it's usually or mostly about the ROI. So I'm investing something into the new technology or into the new connectivity. What do I get from that? And in many cases, if you just talk to certain compartment like the IT organization within the health plan, all the IT organization would care about is how to move the data in, and that's it. But the data by itself is useless unless you can apply this to any meaningful purpose. And this is where you need to talk to different organizations within organization. Like, how can I use this data? Value-based contracts, the quality measures, risk adjustment. All of those things really bring the tangible benefits to health plan. And if you can connect those people from IT, from risk adjustment, from the quality department together to realize the benefits of the data, this is where things will start moving. And this is one of the tailwinds. These things, if you can present the ROI, then these things would really facilitate the adoption. So payers would say, yeah, let's implement this. 57F is a good example. The mandate is designed to just make things interoperable, allow providers to submit prior authorization data. But behind the scenes, there are many things, unlike some other mandates, which bring value to payers. Now they begin realizing that my prior authorization pipeline is so expensive, I have so many people reviewing those prior authorizations. Can I leverage that investment to really address this? So this is when things really become less complicated. So those are all the tailwinds, and there are some more. From the headwinds perspective, sometimes payers don't realize that certain things are mandated by law. So one health plan, representative of one health plan asked me if peer-to-peer exchange is mandatory. So the perception was that it's optional. I may choose or not choose to exchange the data with another health plan. And when I said, no, this is mandatory, you have to do this regardless of what you think, now things are changing. In his perspective, before that, it was just a nice-to-have feature. Now it becomes a mandatory feature. And once it becomes the mandatory feature, new questions arise. How can I make sure that the other plan sends me the right roster? Because if I give him or that plan the information about members who do not belong to that plan, that will be the PHI breach, because essentially I'm leaking out the information about somebody that health plan has nothing to do with, and many more things like that. And having the good framework in place, like TAFCA or other projects that are being done by Da Vinci that would answer those questions is really critical. Because otherwise, everybody or every health plan would either lock this down into some custom-built solution, or will begin reinventing the wheel, and everybody will be treating the things like security, the rosters, the member attribution differently. So education, payer education is one of the key aspects that we spend a lot of time on. So despite so many webinars done by so many vendors and industry experts, payers still think in some cases that certain provisions are optional. Not all the payers, the majority of payers definitely understand things, but nonetheless there are smaller regional plans which don't think this is must have, but this is, some payers still think this is optional. Those are some headwinds which we need to go through in order to make the adoption better.
Okay, so
This one, can I just
Yeah,
have
sure.
that? I mean, Maxim really covered the waterfront there. Not a lot else to add to that, but first of all, I am a little shocked that a payer wouldn't know that they have to do payer to payer at a certain time. But anyway, that aside, the comment you made about the data and the value, I think every one of these things we're talking about, with whether it's prior auth, payer to payer, whatever, those are opportunities for payers to add to their data. And they're becoming pretty open and honest about that, with the criticality of their data lakes and their strategies around that and data acquisition. So this does become just another place to get it, because they do need it for the risk adjustment, the quality and the gaps, just as you said. And I think that that is a value prop that you can bring into any of these conversations for the payers these days.
Yep. Thank you, John. I would argue that they probably need it for the entirety of their operations.
Well, now you're going to get into some risky discussions there. But
All right, so drill down just one level deeper. We talked about, mentioned at the beginning of the conversation that we talk about some challenges. And here's one that is kind of flying under the covers a little bit. Many of you may know about, many of you may not. The Sequoia Project's payer-to-payer work group is currently in a development exercise to augment the existing provider-focused TEFCA endpoint directory to support payers in TEFCA. Now, there are all sorts of challenges with getting payers in TEFCA. I think they can be overcome. But to this endpoint directory specifically, there are some commercial endpoint directories that are emerging in the marketplace. CEQ had one that I believe Edifecs has taken over and is working there as well. There's nothing really in place to address all of the endpoint needs that payers, that providers will have in order to engage with payers efficiently. So I'd like to maybe start with you, Jay, and we'll just make our way down back towards me. What do you think about the endpoint directory issue in terms of national exposure, and how are you working to solve that problem for payers?
Yeah, great question. So I don't think many people would disagree that we do need a national directory, and that might be the TEFCA healthcare directory, both for providers, payers, and other healthcare organizations, or maybe it's part of what CMS is going to roll out with the CMS aligned networks. And as I understand that, they're designing and building that as we speak. So I'm really curious to see what that looks like in the coming months. Within eHealth Exchange, we have, of course, our own FHIR directory. We sync that up with the care quality directory, and we sync it up with the TEFCA directory. And then our poor participants sync it up with their systems. So there's a lot of syncing going on. But yeah, I'm really hopeful that CMS is able to come up with a usable endpoint directory in the very near term.
Mm-hmm. John?
Well, I think we're going to have to do what we've had to do with any endpoint in the Sequoia sponsored directory that we use, and we do exactly what Jay's talking about internally with care quality, QHINs, et cetera. So those endpoints we're going to have to know, and they're going to have to be in the directory just like they are with the provider endpoints. But I think, there's one other step though, and I don't want to get into it too much, but just knowing the endpoints doesn't get you there at scale. Knowing the endpoint will get you from one to the other if you do all the registration and authentication with that server. But to do that at scale, you get into the whole thing with UDAP and Sarah, and I'm not trying to get down into that, but that is a massive consideration that's got to be there to do this at scale. In addition, the next step to the directories.
Right, and
Yeah, that's a
1/1/2020
fantastic point.
1/1/2027 calls for payers to do this at scale. Whether we will or not is a different matter.
Yeah, and again, that talks about the standards and the requirements on the APIs, but I don't know how you ultimately get there at scale without network involvement, again, without UDAP or SARA, and that's not going to be fully, widely available at that date. So.
Right. Maxim?
Yeah, I like to use two examples. Endpoint directory is a necessary evil for now, but in the long term, think about, for example, emails. When I send an email to somebody, I don't really know which SMTP servers this email goes through, or what is the URL or location of that SMTP server. All I know is there is a network. Somehow that network will get my email over to my recipient. And if you take more healthcare examples, like, for example, Epic ecosystem. If I go to a doctor who is on Epic, then all of my information from all other Epic providers will be accessible to that doctor. And again, doctor doesn't need to know like which hospitals I've been to. It's just happening behind the scenes. So something like that is definitely needed for both providers and payers. So whenever the information is needed, and it's bidirectional, it's not like payers just want to suck in all the data and don't share anything back. Payers want to share information back because they pay for the services. So they want to make sure that providers, if I go to a new PCP, payers need to inform that PCP about my previous history. So this PCP doesn't prescribe medications or treatments or anything that is not necessary, because otherwise it will go to the prior authorization, all the medical necessity analysis, and all those costly operations on the payer side. So that is kind of, to my mind, the future is in those distributed networks which can facilitate all the like trust and exchange and connections and endpoints. That is where I think we should be going.
Terrific. So you can see this one small roadblock. We could talk about it really for the entire session, and we might not yet have an answer. I will say we got to move on pretty quickly, but the Da Vinci project has developed a pretty elegant solution for helping providers understand payer endpoints, which really puts the focus on payer-to-payer as the outstanding endpoint piece of work to be done. But nevertheless, we'll move forward.
Can I just?
Yeah, sure.
Because I don't want to just throw cold water on the conversation on the endpoints, and then you need a whole nother thing beyond that. There is work being done there. I've got to compliment the eHealth Exchange. They built a payer gateway. I'll just be your advertised person. I'll be your marketing person. Anyway, but we have no shame. We're totally copying their concept and going to do it. And I think the other networks, if they do that, they're certainly going to help their edge systems that have to do quite a big lift to achieve what we're talking about. Some of the EHR vendors are building that out now, but the dates get way out into 2027 when that's going to be widely available. But again, I didn't want to just say that that's a dead end. There is work being done on that, but it's a major consideration.
Thank you. Okay, so as we get towards about 6 minutes before we need to turn some questions over to the audience, John, payers have traditionally been very functionally siloed, use case oriented in the way they go after clinical data. And they've also had to do that over a very fragmented data market. So what do you think payers should be considering now regarding more of an enterprise level national data exchange scope mindset?
Well, yeah, I mean, if you look at it, kind of at a micro level, it is kind of tight and siloed like that within the payers. But if you look at what intermediaries have done, whether it's your ROI companies that are working with the providers to get that data out, or other intermediaries, the company that acquired us, they are getting the data from any place they can. And probably there's a half a dozen different avenues to get data. And if you were to talk to payers today, and some of the rub with TEFCA is, why would we want to do it? We're already getting it all today anyway, right? I mean, if you talk to them. So it's the intermediaries that are taking what you're talking about, getting as much as they possibly can, and then serving it up to those payers into those different departments. I mean, risk adjustment's got a whole different view of this than HEDIS, as does the people that are dealing with gaps in care, et cetera, like that. But you've got intermediaries that are taking it all, spending that time to get all of it out there from, again, like I said, half a dozen major avenues, and then getting it in, and then serving it up, because what's needed for risk adjustment is different from HEDIS. So they're figuring out which pieces of that data each of those components need, and they're kind of solving that problem that you're talking about. The market and that business model is solving that.
Gosh, I could go down that path with you.
Take the bait.
But I'm the moderator, so I'll
We want some questions, right? I'm sure I'm going to get some questions with that one.
Right, exactly. So Jay, I know from working with you at my time at Arkansas Blue Cross and when we worked on Trebuchet together, that you guys are making some headway with payer engagement, not only at the HIE level, but also moving towards QHIN participation, TEFCA participation with payers. As you are doing that, which data exchange patterns or use cases have been built so far, if any, and where's the focus?
Yeah. So, I think, the payers that I speak with are realizing, or they probably realized long ago, long before I did, that it's not realistic for them to license, a payer platform or a payer portal from each EHR vendor. They're not going to want to buy one from eClinicalWorks and one from Greenway and one from Oracle Cerner and one from Epic and one from Athena. They will go broke quickly. And so, they really, and some of those have enhanced capabilities that are really compelling. So maybe they want to pay for a couple of those, but not one from every EHR vendor. So they're looking for a standardized, scalable approach. And that's exactly what DaVinci provides. So in terms of use cases that I see resonating or exchange patterns, quality data retrieval is certainly one. So the ability to surface and sometimes close care gaps from providers using the HL7 DaVinci CDEX implementation guides. I think that's a super exciting one. And especially if they do it via bulk fire. So we have two of our participants participating in that. And when I say bulk fire, that's the ability not just to get data for one member or patient, patient J, but for an entire roster or population or panel of member patients. Another one is a no-brainer, especially since it's required by the 0057 F rule, and that is the payer-to-payer exchange. I think that one, my crystal ball says that and the HEDIS gap identification are going to be the two that are adopted the most rapidly.
And I can add.
Yeah, please.
We work with eHealth Exchange at Cotiviti on several use cases. again, using FHIR APIs to bring in data for payment integrity, for risk adjustment and quality. So those are payer-specific use cases, not necessarily like Da Vinci use cases, but those drive adoption. And
Sure.
definitely, like you said, very rarely a payer can just standardize on Epic Payer platform or Athena platform. In many cases, they have multiple, and even if they purchase one of these hugely expensive systems, they still have to support other providers on different EMR systems. Sometimes they don't have EMR systems. So this is where work with like eHealth Exchange and other HIEs really help to unify the channel, so they don't need to worry about what kind of EMR system is used by that provider.
Yeah, good point.
Okay, so kind of following on that question, but making this the last question that maybe the whole panel would like to respond to. How can TEFCA and these national networks add value to what you are seeking to do with payers, add value for the payers, and what practical steps might help remove some of the barriers that payers have surfaced around participating in TEFCA?
Go quick. Well, I think one, I mentioned that the payers or the data for intermediaries, they're getting the data today, but TEFCA certainly represents an expanse of the reach for data, not today, but as other, as you go to more downstream EHRs, et cetera, particularly around, oncology, certain specialties, and those get plugged in, you're now going to be increasing access to pretty important data that they want, that they are not getting today. So that's one, to increase the breadth of the data. The other is the timeliness of it. I mean, sometimes they're waiting 30 days for certain things that they will now get in 30 seconds. So those are two things I'll throw out immediately. And then if you want to talk about barriers, there's some resistance or trying to understand the reciprocity component of this. Also, you pass over the terms of participation to a major health plan and you're a year away from that coming off the attorney's desk. So those are a couple of the things that I will mention.
I'd like to add that beyond the legal things, with payers, nobody wants to be the guinea pig. So payers always want this or something to be adopted before them, preferably successfully. So if there is a chance, like all the projects that your organization, Jay, is working on and multiple other projects, whenever there is a successful implementation, let's say there is a payer who implemented the TEFCA for data acquisition for the medical charts for the risk adjustment. And then on the conference, they say, by the way, we did this and we got 5% reimbursement improvement for the risk adjustment. The next day, every other payer would be willing to do the same because all of them, especially in the Medicaid space, where they compete against each other for the same pool of money, they would be willing to adopt the same technology. So I would say good practical implementations and examples would be very beneficial in moving things forward.
Jay?
Yeah, go ahead.
I just want to tee off that for a second because you're getting a theme here. I mean, you hear about the CMS-aligned networks. Those are smaller projects to prove you can do something, prove there's some benefit. What Jay's talked about, what you just talked about, you've got that is informing the market, et cetera. And then you've got these national networks that are trying to do a big major lift. But to your point, if you've got some success stories that they can look at, that also helps bring them in. So if you've got the big broad thing that's going on and then some targeted pilots that are having success, both of those work together.
And payers won't be shy in advertising their success. Yeah. So that'll be really beneficial.
Yeah, Levitt Partners is facilitating that in a number of geographies. You hear about Utah quite a bit. And then Point of Care Partners is doing that in Washington State. So I think those, starting small, starting locally, get some trust going. I think that certainly is a great place to start. And you're right, it creates the proof points. In terms of what TEFCA could do, if I understood the question properly, the fees. The fees have driven me nuts since day one. The ability in TEFCA for providers to charge payers fees has really turned the payers off. So I would urge TEFCA to evolve and no longer permit the charging of fees.
Great suggestion. So,
It's a very delicate question.
John will pay the fees.
I'm sure we could talk about that quite a bit
that's
in
a
here as
whole
well,
nother-
and maybe that's where some of the questions will come from. There are some good answers to that point, but maybe there are good answers on both sides of the question. So we've got plenty more questions that we can cover here, but we thought we'd give some time for the audience to make some inquiries, if there are any.
So, Mike Bailey, United Health Group. We've been wanting to join networks for the last 7 years. When will payment and ops be required? And we had the last session where people did thumbs up, thumbs down, right? We want to get data, but, right, we got to be able to get it back. And, I mean, we've had to build, and I'm hearing pilots where it's scale through EMR vendors. We bring ADTs back at scale. Right, I mean, we're there. You guys mentioned it. Risk adjustment, HEDIS. We employ more nurses than any health system in the country. We do more care management, but we can't do treatment. I mean, I've heard everything. It's really just a simple question. When will you require payment and ops so that basically we will give data to get data, which is how all the exchanges work. So we're open, interested, want to do it, because we've had to negotiate no less than 125 contracts individually with HIEs, EMR vendors to go get this data. So we are in a kind of, when can we get to the National Health Information Networks at scale? And kind of like CMS, where we literally just had to go do it on our own through private industry, go negotiate the fees, negotiate the way we get the data. But there, in a value-based care world, is an absolute desire to push data bi-directionally to where it needs to go for better patient care. And so as we talk about how do you get payers to join, when will payment ops be available? And in February, is operations going to be turned on?
I wish that I was the right person to answer that question, but I think they're sitting somewhere else in the audience. It's a really, really good point. And you also brought up the value proposition that I was going to mention earlier. But, you know, the data exchange requirements for payers is exceptionally fragmented, and that is very costly. And the promise of TEFCA is to alleviate much of that. But we've got to get past issues like you've mentioned and Jay's mentioned on pricing. You know, providers don't pay payers when they send in clinical data to support a claim. So really, why is this any different? Maybe another food for thought for some questions. What is the data requirement for these different use cases? We're stuck in this mindset, perhaps, of more detailed use cases, right? But healthcare operations and payment are the HIPAA-defined use cases. And if you look at those, the data required to support those, it's virtually every data element that a payer might need, and none that they don't. So perhaps there's a way to pay for payers to settle on a common data request, and maybe that eases the burden with providers. Nancy, you're standing. That means you want to.
There's so many things I could say. Number one, first thing is I do disagree that about the fees thing. Payers are willing to pay for data. We pay for data all day long, don't we, Mike? I loved everything you said, 100% support it. We pay a lot of money for data, and we're willing to do that because it's valuable information for payers. Second of all, to your point, I think trying to solve this use case by use case is never going to get us there. Payers have been getting encounter records since the beginning of time. You've been faxing them to us, you've been emailing to us, you've been sending them to us. We're not asking providers to change what you're doing, what you're sending. We're asking you to change how you send it. And I need it once. I don't need one. I don't need a little sliver for quality and another little sliver for risk adjustment and then the whole encounter record for claims review. Send it to me one time and know that I'm a HIPAA entity as well, and I have to follow HIPAA, and I have to make sure I protect that data and only use it for the right use cases. Back to the trust conversation we had earlier, we have to start trusting each other that we all are governed by HIPAA and we act accordingly. So send it to us one time, give us a single on-ramp. You're not sending anything you haven't been sending for years and years and years, just change how you want to send it and trust that we're going to do the right thing. And we'll pay for it. We're not asking to have it for
That's kind of what
free.
you've been advocating for years, right? The fact that after each encounter, the payer should be able to get the entire.
An encounter record, many payers are moving in this direction to maintaining longitudinal records of their members, because as we move into the AI space, the data manipulation, the data understanding that AI can help with needs a longitudinal record to be able to address that. So a strategy for a smart payer might be that, and provider organization, that you just send an encounter record at the close of every encounter. The payers build a longitudinal record, and then over time, they need to request less and less data of you, none of these 100-page reports and so forth. There's a lot of ways to skin the cat, so to speak. Maybe some of you have some other thoughts on that.
Well, I just want just a second. I want to just try to get at the first question. We're not the ones that decide about whether it's mandatory or not to respond. But Matt, you and I sat through many long days down in D.C. hammering through this with the organizations, and it's not an easy one. As you know, and as you mentioned in February, it's supposed to click and become mandatory. I mean, I can offline handicap that, whether I think it's going to happen or not. But a lot of that gets into the market today. And if there's $2 billion being made a year in aggregate to buy this data, and to think that that's going to roll over and go away because it's mandated to give it free, there's the issue, not us. And I think the other comment about you're willing to pay for data, my guess is if it was to go through TEFCA and you were able to still get paid, it'd probably be a lot cheaper than what you're paying today. That's one thing. So maybe free is not, you're not going to get it free, but maybe for way less, quite likely. And then also much more efficiently. Those are some other reasons. But I hear what you're saying, having to handle 128 or whatever you said, contracts to get your data is a problem. I do think ultimately some of that in the middle will shake out and consolidate. That's not going to fix your whole problem. But again, we're not the ones that decide when, if you can or can't, if you have to respond. But like I said, Matt and I have been through the discussions, and we understand the issues.
We've got less than 2 minutes for another comment, if there is, or question.
Hi, David Figueredo, MedAllies. I love this work group. I love the problems you guys are tackling, the payer-to-payer interchange, and how that can fundamentally change the cost and the efficiency of healthcare. But there are problems that I don't hear being talked about that are systemic, that are driving massive waste and abuse in the market. So I'll take, for example, for the last 5 years I've been working on coordination of benefits issues, right? The payer-to-payer communication issues. And when you look at the data, it's actually pretty clear that about a third of COB denials are data inaccuracy, data integrity issues caused by the payers where they have outdated information because they can't properly communicate from payer to payer. Can you talk a little bit about how the TEFCA interchange and the Sequoia project are tackling those kinds of problems? Because we look at the amount of wasted labor, the impact to patient satisfaction, member satisfaction rates, billing errors, right? So much of it is caused by simple things that could be solved through better interoperability and mandated interoperability validation processes for COB records, as an example. If you can.
Folks. So
You don't want to touch it, okay. Well, right now, we're just trying to get the foundation laid so that the tracks are in place. And, the first floor might be stakeholder involvement. We don't even have the payer stakeholders involved yet. Certainly, I see Dee Dee back there. She's probably can't wait to do this. But at some point, we're going to get into content, and we're going to start to get into what you're talking about. That's not today, but that will come. But at first, we've got to get this stuff flowing and those connected. But ultimately, if we can't tackle what you're talking about on content, then we lose a ton of the opportunity. So I agree with what you're asking for. We're just not there yet.
And guys, our time is up. I would just say quickly to your question, payers are starting with FHIR IGs as a mechanism for exchanging data. And that's a radically different place than where providers started in their exchange. So I'm hopeful that that is a leg up in getting to solve some of the problems that you've identified.
So everybody needs to cross their finger on that comment. Anyway, thank you.
Thank you.
Thank you.
Alrighty, well, we're going to be breaking for lunch in just a minute. Thank you to SureScripts for sponsoring lunch today. It is on the 4th floor. Also, after lunch at 1:30, there are going to be 2 unconference sessions. This room is going to be split in half. One of the spaces is going to focus on data usability and data quality, and the other one is focused on what is a provider. And that is not an existential question. It is actually a legitimate question about, in a TEFCA context, a lot of discussion and debate is on, who and when are you required to respond. So back at 1:30, and we'll talk to you soon.